Good afternoon, everyone. Pediatric Center of Excellence at Kalavati Saran Children's Hospital, New Delhi welcomes all the participants for today's RDLS session. Today's topic is common comorbidities in CLHIV, and the speaker is Dr. Harshita Gosainwal. Dr. Harshita ma'am is currently working as the medical officer with the ART Center at KSCH Hospital, New Delhi. We welcome you, ma'am, for today's session and request you to start the session.
Thank you so much, Shweta, for the invite. Good afternoon, everybody. Am I audible and the screen is visible?
Yes, ma'am.
Okay, I'll start with the session. So today's topic is common comorbidities in CLHIV. So, just a second. So today the discussion will be on, we'll do the introduction and we'll discuss some of the topics like malnutrition, anemia and thrombocytopenia, hepatic dysfunction in CLHIV, chronic respiratory morbidities in CLHIV, neurological morbidities in CLHIV, and other comorbidities. So let's start with the session. First, the introduction. So at the time of HIV diagnosis, a CLHIV or a children living with HIV may have a variety of clinical manifestations, as we know, depending on their age and the severity of immunodeficiency. These manifestations may involve one or more systems and influence the clinical staging of HIV, ART regimen, and as well as the treatment for these conditions. This systemic involvement has a direct influence on the health status and mortality, and an indirect influence on the ART adherence due to the drug interaction and added pill burden. So, all the system may be involved either directly by HIV virus itself or secondary to the other opportunistic infection. So, what are the common comorbidities in CLHIV at the time of diagnosis? The patient can have infection that could be tuberculosis, there can be any bacterial infection, a fungal infection, or a viral infection, which can be localized or disseminated, that is sepsis. According to the nutrition, the system involvement for nutrition and the manifestations can be child can have wasting, stunting, any vitamin deficiency like vitamin A deficiency, vitamin D deficiency. And for the GI system, patient can have recurrent, persistent, or chronic diarrhea. The patient can have oral or esophageal candidiasis. Patient can have recurrent or a persistent oral ulcers. For the hepatobiliary system, the patient can have hepatitis infection, that is hepatitis B, hepatitis C, and hepatitis due to other organisms like A or E also. And the hematological system we can have anemia, thrombocytopenia. For the central nervous system, we can have delayed development regression, meningitis due to various bacterial, viral, and fungal infection, including TB and cryptococcus, and HIV encephalopathy. For the respiratory system, we can have recurrent or a persistent pneumonia, bronchiectasis, sinusitis, chronic otitis media, or lymphoid interstitial pneumonitis, that is LIP. For skin and soft tissue, infections can be bacterial or a fungal infection. There can be nutritional dermatosis. There can be scabies. There can be molluscum contagiosum. There can be herpes zoster and a PPE, that is pruritic papillary eruptions. So we'll discuss about malnutrition first. What is malnutrition? Malnutrition is extremely common in CLHIV. The infant and young children are more likely to present with wasting. So older children who may have an intermediate disease progression and are more likely to present with stunting. Malnutrition is an important cause of mortality in CLHIV, especially in the developing world like our country, India. Children with mild to moderate malnutrition can be managed on an outpatient basis or a OPD basis. Those with severe acute malnutrition will require admission, hospital admission, and therapeutic feeding. So, how do we classify nutritional status of a less than 5 years old child? By using anthropometric indices. We'll take the weight for age, we'll take length or height. We'll take, if a child is less than 2 years of age, we'll take the length. If the child is more than 2 years, we'll take the height for age. And then we'll take the another anthropometric indices, that is weight for length or weight for height. And the nutritional status may be graded in four categories, that is normal, underweight, stunting, or wasting. So you can see there are SD score or Z score on one side, and there are the indicators, the three indicators which we have used. One is weight for age, The other is the height or length for age. And the third one is weight for length or height. So you can see if the median or the SD score is below -1 standard deviation, the weight for age will be normal. The height or length for age will be normal. The weight for length or height will be normal. Now, if we have standard deviation less than minus less than 2, the weight for age will be moderately underweight, and for height for or length for age will be stunted, and for weight for length or height they'll be wasting, that is moderate acute malnutrition. So, and the most important is when the SD score is below -3 standard deviation, the weight for age the child will be considered as severely underweight. Height for age or length for age will be considered as severely stunting, and weight for length or height, it is severely wasted or severe acute malnutrition, that is SAM. So most important, remember when the child is minus two standard deviation, the weight for age is moderately underweight, and height for length is stunted, and weight for length is wasted or moderate malnutrition. And if a child is below -3 standard deviation, the child is severely underweight for according to her weight for height, and severe acute malnutrition or severely wasted according to weight for height or length. So, what are the combined uses of anthropometry and clinical parameters? When, as we have discussed, in severe acute malnutrition, the weight for height or length is less than -3 standard deviation, or there can be visible severe wasting, or there can be mid upper arm circumference, that is MEUAC, which is less than 11.5 centimeters, or a patient can have edema of bilateral feet. For a patient who is having moderate malnutrition, the weight for height was between -2 to -3 standard deviation, and the mid-up circumference is between 11.5 to 12.5 centimeters, and there will be no edema and no severe wasting. So, as these are the WHO growth charts, that is which contains weight or length or height charts. In this, you can see on the left side there is boys' weight. In the center you can see this white row going, that is for the length, and on the right side you can see the girl's weight. This part of the graph is for whose height or the length is less than 87 centimeters. This part of the graph when the height is more than 87 centimeters. So let's suppose we take a baby whose length is 45 centimeters, and the child is a girl child whose weight is -3 standard deviation. So you will label the child as SAM or severe acute malnutrition. So I've discussed this SD score for weight for length and height. Okay. So how do you measure the mid upper arm circumference? That is MUAC. Everybody must have seen this Shakir tape with you in a pediatric OPD, or you must be having in your center. So it is a colored coded tape. You can see there is red color, yellow color, and green color. So we take a child left arm. You locate the tip of the shoulder. The second one is when you look at the tip of the shoulder and tip of the elbow, you place the tape at the tip of shoulder and pull the tape past the tip of the bent of the shoulder. Now you mark the midpoint between the tip of the shoulder and tip of the elbow. So the midpoint will come, and you can see there are three pictures in this. This is the correct tape tension. See, in this figure number 8, in this the tape is too tight. You can see a bulge like this coming here. And in the image number 9, the tape is too loose, and you can see there is some of the empty part here. So this is the correct way. The seventh number image, that is the correct tape tension. You take the arm circumference like this. So here, this is the window where you take the reading. So in this Shakir's tape, you can see there's a window to read, and there'll be a slit you can pass through your tape. Okay. So according to the MUAC you have taken, we use three color MUAC tape. Color zones are, as we have read, seen also green, yellow, and red. Green obviously indicates the child is well nourished and the MUAC is more than or equal to 12.5 centimeters. A yellow color zone indicates the MUAC measurement is about 11.5 to 12.4 centimeters. That is moderate acute malnutrition. And in the red tape, you've seen the MUAC measurement is less than 11.5 centimeters, and you define child as severe acute malnutrition or a SAM child. So how do you check? You can see this baby who is having wasting or a severe wasting. Now, how can you define it? Look at the front view of the child and decide, is the outline of child's rib seen easily? We can see that. Does the skin of upper arm looks loose? Does the skin of thigh look loose? And how do you, and from the back, how do you see it? Look at the back of the child and decide. So you can say, look at this. This is the back of the child. Are the ribs, shoulder bones, and spine easily seen? Is there any wasting seen on buttocks, which we can see? Okay. So now how to check for bilateral pitting edema? So the edema in severe acute malnutrition starts from the dependent part, that is the feet of the in a mobile child. As the severity of the edema increases, it can extend to the legs, and in severe cases, it may also be seen on the upper limbs or face that you call as anasarca. How do you check for edema? You need to grasp both the feet so that they rest in your hand with one thumb on top of each foot. So you'll take patients both the feet, you'll grasp and let it rest in your hands. You press with one thumb on top of the each. Now press your thumb gently for a few seconds, prox 10 seconds, not more than that. Child has a bilateral pitting edema if it pits or dents remain in both feet when you lift your thumb. In this picture, you can see we have taken patients both the feet in a resting in our hand. We have put our thumb, press the thumb gently for 10 seconds, and you can see there is denting or the edema present in bilateral feet when we lift our thumb. So this is the edema, bilateral pitting edema, which we see in the children of severe acute malnutrition. Now, how do you manage the children with moderate acute malnutrition? You need to assess for their feeding practices, like they're having good feeding practices, underlying medical condition. You need to counsel mothers or the caregivers so that they can give feeds in adequate amount, frequency which has adequate energy density and are hygienic. This is the most important point, that the feed which they give, the frequency, the amount, the energy dense, the adequate energy dense, and should be hygienic. You need to counsel for food diversity and active feeding and you need to follow up after 15 days. There sh- so underlying medical condition is identified like cleft palate, congenital heart disease, infection, etc. They should be treated or referred to a higher center. If there is no underlying medical condition are identified, you should counsel mothers for giving appropriate feeds for the age. So, how do we do the SAM management? You can see the child has no appetite and there are medical conditions as we have discussed previously. So, we'll give a facility based treatment for the child. That the intervention is you give the feed 75, F75, followed by F100, or you can say ready to use therapeutic food and 24-hour medical care. Now, what is the discharge criteria? Like the transition criteria from a facility based to the community based care, when there is edema is reduced, the patient is having good appetite with acceptable intake of ready to use therapeutic foods. Now in the second criteria, the appetite is normal, there's no medical condition, you will do the community based management. That is, you will give ready to use therapeutic feed, you will give the basic medical care. And when will you discharge the patient? When there is a weight gain of 15 to 20%. So indications, what are the indications for hospital management in a SAM child? The indications are there is a presence of any emergency sign, there is hypothermia, there's edema present, persistent vomiting, the child is very weak and apathetic. There is fever, that is the auxiliary temperature is more than 39 degrees Celsius. There is fast breathing, chest and drawing present, extensive skin lesions and eye lesions. There can be diarrhea with dehydration, severe anemia, purpura or bleeding tendency. There's evidence of systemic infection or complication. There can be clinical signs of secondary cause of severe acute malnutrition. Now, as we have completed malnutrition topic, we'll move to anemia and thrombocytopenia. So, what is anemia? Anemia is a condition in which the number of red cells is insufficient to meet the body's biological needs. So, what are the hemoglobin levels to diagnose anemia? We have the age criteria, that is when the child is of 6 months to 59 months, that is 6 months to 5 years, less than 5 years of age, hemoglobin level is less than, if the hemoglobin level is less than 11 gram deciliter, and in 5 to 11 years of age, hemoglobin is less than 11.5 gram per deciliter. And in the child is more than 12 or equal to 12 years, the hemoglobin is less than 12 gram per deciliter. But for the severe anemia, for the child who's between in 6 to 15, 9 months of age, if the hemoglobin is lower than 7 gram per deciliter, you consider the child as severe anemia. And for 5 to 11 years of child, you'll consider severe anemia when the hemoglobin is level is less than 8 gram per deciliter. And for a child who is more than 12 years of age, if the hemoglobin is less than 8, you will consider that child as severe anemia. Anemia is present in a large population or a proportion of CLHIV at presentation. The important causes are anemia of chronic disease or any nutritional deficiencies. In a patient of ART with rapid development of anemia, zidovudine-induced marrow suppression is a likely cause. The children who are on zidovudine-based drug. What are the causes of anemia in CLHIV? One can be a decreased production, and other can be an increased loss or a destruction. So in the decreased production, we can have deficiency like iron deficiency anemia, B12 or a folate deficiency or a megaloblastic anemia in we see, or there is a erythropoietin deficiency. Infections like malaria, Kala Hazar, HIV, CMV, that is cytomegalovirus, EBV, that is Epstein-Barr virus, parvovirus can have aplastic anemias, TB, and MAC and histoplasma. Drugs like zidovudine, primoxidol, that is Cepran, amphotericin B can have anemia. Anemia of chronic disease and malignancy like Hodgkin's lymphoma and non-Hodgkin's lymphoma, where now we have causes of increased loss or a destruction when there is hemolysis, that is autoimmune hemolytic anemia, there any pre-existing condition like thalassemia, any GI bleeding which is present in infections like CMV, Candida parasites, or a bowel lymphoma, and hypersplenism. How do you evaluate a CLHIV with anemia? First, we'll start with the history. A child will come with you with complaints of easy fatigability. Mother will say, बच्चा बहुत जल्दी थक जाता है, बहुत चिड़चिड़ा रहता है, that is irritability. The patient can come with complaints of anorexia, like ये खाना नहीं खा रहा है, उसकी mother complain कर सकती है. The patient can complain of pica, that is patient मिट्टी खा रहा है, और वॉल दीवारों से मतलब जो वॉल पेंट होता है उसको लेके खा रहा है. द पेशेंट इज लुकिंग पेल टू यू, देयर इज पुअर स्कूल परफॉर्मेंस, देयर डिस्नी ऑन एक्सर्जन एंड palpitation, dizziness, or a headache. Now you need to elicit the following history. Is there any blood loss, epistaxis, there's nasal bleed, any melena, any perrectal bleeding due to anal fissures? There can be menstrual losses in adolescent girl. Chronic diarrhea or a recurrent jaundice you need to rule out. You need to ask for the drug intake, like if a patient is taking any anticonvulsant, any zidovudine, patient is taking zidovudine, patient is taking Septran or not. Now can be a repeated blood transfusion history like bleeding disorders and thalassemia. The past history, the chronic infections like liver and renal disease should be ascertained. Now you would need to take the family history also. There is severe anemia in the family requiring frequent blood transfusion. There can be bleeding disorders in the family. Recurrent jaundice or gallstones usually indicate hemolytic anemia. Now you need to take the dietary history of the patient. That is the most common cause of anemia in children is the nutritional anemia. So this is a very important point. The most common cause of anemia in us children or CLHIV is nutritional anemia. The type of milk given after birth and age at which the complementary food was introduced, like cow milk have less of iron, history of pica present, which increases the risk of helminthic infection. So how do you do the examination? A general head to toe examination is essential to look for signs of anemia, any vitamin deficiency, any lymphadenopathy, splenomegaly, and the signs of congestive cardiac failure. Pallor can be assessed by comparing the child's palm with your own to judge the severity of anemia. Presence of jaundice indicate possibilities of hemolytic anemia. There can be tachypnea, tachycardia, hepatomegaly may indicate a congestive cardiac failure that may accompany severe anemia. There can be petechial rash, lymphadenopathy, or any organomegaly, which will point to lymphoreticular malignancy. The patient can complain of angular stomatitis, glossitis, cholangia, and signs of vitamin deficiency, which may also be present. Now, what are you've asked the history, you've done the detailed examination, detailed head to toe examination. Now you'll do the investigation. First, you'll do the CBC, that is a complete blood count. You'll check for the hemoglobin value, and which will confirm the diagnosis of anemia and its severity. In the peripheral blood smear, you can see different types of cell. That is, for the micro, if there are microcytes present, you will diagnose the child as microcytic anemia is usually due to the iron deficiency. But thalassemia is an important differential diagnosis for a microcytic anemia. If there are macrocytes, you label the child as macrocytic anemia, which is most likely due to B12 and folic acid deficiency. For a normocytic normochromic anemia, anemia of chronic infection, acute blood loss can be there. And if there is a pancytopenia, like if there is WBC, hemoglobin, there is hemoglobin, there is WBC and platelets decrease. The patient can have aplastic anemia and lymphoreticular malignancy. Now you can see the reticular, now you have to see the reticulocyte count. If there is an increased reticulocyte count, there is an ongoing hemolysis and or a non-chronic blood loss. If the reticulocyte count is low, there is bone marrow depression is present. How do you manage? What are the components of management of anemia? First, you'll do the deworming. So it is important point for all the CLHIV, we need to do deworming once in 6 months. And how do you do it? You need to administer a tablet or a syrup albendazole 200 mg, single dose for children up to 2 years of age. And if a child is beyond 2 years of age, you give a single dose of 400 mg. So when the child is less than 2 years of age, you give a tablet or a syrup albendazole 200 mg. And for a child who is more than 2 years of age, you give 400 mg, a tablet or a syrup of albendazole. How do you start with iron and folic acid therapy? You need to supplement with oral iron at a dose of 3 to 6 milligram per kg per day of elemental iron. Iron absorption is best when taken on an empty stomach or in between the meals or 1 hour after the meal. Anemia usually gets corrected over 2-3 months of the treatment. Oral iron should, however, be continued for another 2-3 months to replenish the iron stores. Folic acid dose around 100 to 200 microgram per day is adequate to treat associated folic acid deficiency. Now you need to do the nutritional counseling also. You need to tell mother or a caregiver about iron-rich food items such as green leafy vegetables, peanuts, jaggery, egg, chicken, etc. Milk and milk products are poor sources of iron. So always remember, whenever you're giving iron, you don't give calcium supplement or milk, tea, coffee. These decreases the iron absorption. When to refer to a pediatrician for an evaluation? Those with severe anemia with or without congestive heart failure, those with a galactosic anemia or pancytopenia on hemogram, those with clinical features suggestive of hemolytic anemia or lympholiticular malignancy, those who are not responding to hematins. Now, what is thrombocytopenia? As we all know, the normal platelet count is about 1.5 to 4 lakh, and thrombocytopenia is referred when the platelet count is less than 1 lakh. Thrombocytopenia is also commonly encountered in CLHIV and may be an initial manifestation of HIV infection. Etiologies include the following, that is, immune-mediated platelet destruction, thrombocytopenic, thrombocytopenic purpura, impaired hematopoiesis. Bone marrow studies are needed for evaluation of the cause. Management is usually the same as in HIV non-infected children. Once causes like malignancy and aplastic anemia are ruled out, most CLHIV with mild thrombocytopenia will respond to ART itself. All children with thrombocytopenia need to be referred to a pediatrician for the evaluation. Now we have completed the two topics, that is malnutrition and anemia and thrombocytopenia. Now we'll discuss the hepatic dysfunction in CLHIV. So what are the causes of hepatic dysfunction? Hepatomegaly and mild elevated liver enzyme, that is AST, ALT, or ALP raise, are common in CLHIV, though chronic and progressive liver disease is unusual. What are the common causes? The patient can have a co-infection with viruses, that is hepatitis A, B, C, or E, or a CMV or a EBV, co-infection with MAC or Cryptosporidium, fatty liver, or a drug toxicity. What are the clinical manifestation? So you need to have history that patient is complaining of any jaundice, anorexia, nausea, vomiting, fever, any right hypochondriac pain, any pruritus or a rash, and pale colored stools. What do we look for in the examination? We can see if there are any icterus present, any hepatomegaly or decreasing span of liver size, altered sensorium, irritability, and altered sleep patterns, poor feeding, ascites, and bleeding manifestations. So, how do you investigate a child who's having hepatic dysfunction? The investigations are you'll do the liver function test, that is total or direct serum bilirubin, or you can say the serum ALT and AST. Enzymes like ALT and AST are usually elevated. You do the peripheral smear to rule out malaria. You'll do the testing for Hep B and Hep C, or and HAV testing and HEV testing also for hepatitis A and E virus. You'll do the blood glucose testing. You'll do the prothrombin time, electrolytes like sodium and potassium. The presence of jaundice recently onset is indicative of an acute hepatitis. It is essential to gauge the severity of the dysfunction, that is, there is a hepatic encephalopathy or a coagulopathy there or not. How do you treat it? The hepatic dysfunction for a CLHIV? Remove the potential offending medication as per the ARV adverse drug event guidelines. If the child is on ATD, you do the institution of modified anti-tubercular regimen. You give the supportive care, that is monitor nutrition and rest. For any hepatic failure, monitored intestinal decontamination with lactulose and neomycin, low protein intake, vitamin K. You can give fresh flows in plasma, antibiotics, and correction of dyselectrolemia, antacids or a H2 blocker, and you can give oxygen or ventilation. There can be presence of hepatitis and its severity and etiology influence the initiation of the ART as well as the drug regimes. Many ARV drugs, especially nevirapine and protease base inhibitors, have associated with hepatotoxicity. Like you have seen the unconjugated hyperbilirubinemia in atazanavir patients. Now, we'll discuss about the chronic respiratory problems or morbidities in CLHIV. First is bronchiectasis. What is a bronchiectasis? It's a disease characterized by irreversible abnormal dilatation of bronchial tree. It is classified as a WHO stage 3 clinical disease. There is all the time persistent cough and fever with productive purulent sputum or hemoptysis should arouse the suspicion for a bronchiectasis. Clubbing is usually present. On a chest examination, you reveal localized signs which do not easily resolve with the usual antibiotic treatment. Chest X-ray may show cystic spaces, occasionally with air fluid levels and honeycomb pattern. How do you manage a case of bronchiectasis? The acute exacerbation need to be treated with adequate antibiotic therapy that can be given for 2 to 4 weeks and post-dural drainage of the sputum and chest physiotherapy. Antibiotics should be carefully chosen to cover a broad spectrum microorganism, including gram-negative bacteria too. Attempt should be made to isolate the organism by sputum culture or induced sputum or a GA sample or secretion obtained through bronchoscopy, that are the bowel sample. The treatment involves administration of antibiotics during acute exacerbation and bronchodilators are also advised. Surgical treatment may be necessary if the symptoms are severe or refractory to medical management and the disease is limited to one segment or a lobe. What is LIP? That is a lymphocytic interstitial pneumonia. LIP or a stage 3 clinical condition is a lymphoproliferative and a non-infectious pulmonary disorder. characterized by diffuse infiltration of CD4 lymphocyte, plasma cell, histocytes in a alveolar septa, along with the lymphatics. Most common in children infected with HIV, especially those who are aged around 2 to 3 years of age. The disease usually has an insidious onset of mild, but the persistent cough with or without exertional dyspnea and breathing difficulty and associated clubbing can be there. LIP should be suspected if the child does not respond to the antibiotic therapy or if the chest X-ray finding persists or worsen despite appropriate antibacterial and antitubercular treatments. Treatment of LIP, that is a lymphocytic interstitial pneumonia, includes bronchodilators and corticosteroids. Corticosteroids are given for the short course for mild intermittent symptoms and a long course with a slow taper in the chronic cases. Always remember while you are evaluating a HIV infected child with respiratory system, it should be remembered that the patient may be having more than one clinical entity responsible for his or her symptoms. It is infrequent for a patient to have TB and bronchiectasis or TB and LIP or LIP and bronchiectasis. Now, what are the neurological comorbidities in CLHIV? Pathogenesis, this is the pathogenesis of a neurological illness in HIV. Now the HIV enters the brain through infected monocytes and T lymphocyte that cross the blood-brain barrier. There is a direct invasion of nerves by the virus, which will lead to inflammation, degradation, and disruption of neurotransmission, vasculopathy, and demyelination. In children, all these changes occur in an immature brain, and hence morbidity is more severe as compared to the adults. What are the risk factors for neurological involvement in CLHIV? The route of transmission. Higher risk of neurological morbidities in children with perinatal transmission. Severely immunocompression in child. That results in a high plasma viral load in blood and CSF. The age of the child. Highest incidence of HIV related CNS manifestation occurs in first 2 years of life. This is a very important point. So and with the incident rates of 9.9% in first year of life, 4.2% in second year, and in the third year for life, that is less than 1%. So this bracket, the first 2 years of the life, there is highest incidence of HIV related CNS manifestation which can occur. There can be presence of any other comorbidities like prematurity, low birth weight, poor nutritional status. What are the spectrum of primary neurological manifestations? HIV associated neurocognitive disorder, which can vary in severity from an asymptomatic neurocognitive impairment to severe dementia. The patient can have stroke syndromes, which will initially lead to HIV associated encephalopathy. What are the general principles for management of neurological morbidity? CNS involvement in CLHIV can be subtle. You need to assess neurodevelopment and look for red alert or a red flag in a HIV infected children, especially in infants and toddlers. For a syndromic approach to identify etiology, neuroimaging can be very helpful, like MRI can be very helpful. Early detection of HIV infection through systematic follow-up and evaluation of HIV exposed infant and timely ART initiation is key to mitigate CNS insult. Effective ART can prevent and to some extent reverse the neurological signs and symptoms. What are neurological manifestations in CLHIV? Children who are less than 5 years of age, they can have a global delay in achieving the milestone. That can be a motor or a cognitive delay. There can be static or regression of milestones. There can be acquired microcephaly. There can be progressive spastic paralysis. There can be pyramidal tract sign like basal ganglia dysfunction, which is very rare. Patient can have ataxia, seizures. And children who are older children, like from 5 years to 15 years, there can be slow progression of or regression of learning milestone. There can be attention difficulties. There can be impaired cognitive function. That is, conversation will be a difficult task for the child. Comprehend, the child will not be able to comprehend properly. There can be perception motor activity impairment. So, what is HIV encephalopathy? HIV encephalopathy is the most common CNS manifestation of pediatric population. It can occur in the first few months of life and may precede signs of immune deficiency and other systemic manifestation of the HIV disease. HIV encephalopathy is diagnosed if CLHIV have one of the following signs for 2 months in the absence of demonstrable causative organisms. First is failure to attain or loss of developmental milestone, or there is a loss of intellectual ability. There is progressive impaired brain growth demonstrated by stagnation of head circumference. There can be acquired symmetric motor deficit manifested by any of the two following signs. That is, there can be paresis, exaggerated reflexes, ataxia, or gait disturbances. So, CT scan of the brain can show cortical atrophy and bilateral basal ganglia calcification in a patient of HIV encephalopathy. MRI can, in HIV encephalopathy, may show again the cerebral atrophy, the cerebellar atrophy. There can be calcifications again basal ganglia. There can be sign of attenuation of white matter. HIV encephalopathy, even when arrested by ART, leaves residual cognitive and motor deficient with significant impact on independent mobility and daily living. Frequent association with lack of nurturing, a poor social environment, and a parental sickness contribute towards overall poor development of these children. This poor school performance and dropping out of school is very common. How do you manage patient of HIV encephalopathy? All HIV exposed and infected children must undergo routine development assessment at the presentation and during follow-up visits. A detailed evaluation is needed for children with developmental delay, poor scholastic performance, or any behavioral issues by a pediatrician. They will need a referral to a pediatrician and a psychologist as appropriate. So, what are the other comorbidities? There can be cardiomyopathy. Cardiomyopathy, all the components of cardiovascular system might be affected during the course of HIV. It is very likely that a HIV-related cardiac disease has a multifactorial origin. Dilated cardiomyopathy is the most common cardiac complication of HIV infection in CLHIV and is an adverse prognostic indicator in patients with HIV infection. Zidovudine has implicated in the etiology of cardiomyopathy, though its role has not been firmly established. CLHIV and zidovudine-based ART should be monitored clinical for evidence of any cardiac diseases. Early atherosclerosis may be a new emerging disease in HIV-infected children. Now, what is pulmonary artery hypertension? How to do a child present? What is pulmonary artery hypertension? Pulmonary artery hypertension is a serious disease of pulmonary artery. It is characterized by an increase in pulmonary vascular resistance and pulmonary arterial pressure. The pulmonary arterial hypertension is defined as resting mean pulmonary arterial pressure, which is greater than 25 mmHg, or the mean pulmonary artery pressure following an exercise that exceeds more than 30 mm per mercury. The child usually present with exertional breathlessness due to the inability of the right ventricle to raise the cardiac output with exercise. The other symptoms are hemoptysis, chest pain, congestive heart failure, dizziness, a syncope, or arrhythmias. How do you diagnose and manage pulmonary artery hypertension? You need to do the chest X-ray that may show cardiomegaly and pulmonary artery enlargement. ECG is usually diagnostic with right axis deviation and a right ventricular hypertrophy with right axis deviation. HIV-associated pulmonary artery hypertension is confirmed only after all other possible causes of PHA have been excluded. Hence, all the children with signs suggestive of PHA need an urgent referral to a pediatrician. So, we have completed today's session. We have discussed very common comorbidities pertaining to CLHIV. Anybody has any doubts or any question pertaining to this?
Any questions? There are no questions in the chat box.
Yeah. Okay.
Any questions on comorbidities and CLHIV? You can unmute and you can ask questions. Ma'am, I don't think. questions. Thank you so much for
Okay.
facilitating this session.
Thank you, Shweta. Thank you so
Thank you, ma'am.
much.
Thank you. Kiran sir, can we quickly run the feedback form? Yes, thank you. Feedback poll is now visible on your screen. Participants are requested to please attempt all the 5 questions. Please read the last question carefully before answering it. Requesting all the participants to please attempt the feedback poll. Kiran sir, we can end the feedback poll now. Thank you, ma'am. Thank you so much. Thank you to all
Thank
the
you. Thank you,
participants.
Shweta.
Thank you to all the participants for patient listening. We'll conclude the session now.